hello everybody, and happy Tuesday to all. My name is Benjamin Suter. I am the Public Education and Outreach Coordinator for the Cancer Center here at Grady Memorial. I want to thank Ms. Brenda Colbert as well as the Lou Walker Senior Center for providing Dr. Goldenberg and I the opportunity to spend some time with you all and kind of provide some education regarding breast cancer awareness and detection during October, which is Breast Cancer Awareness Month. With us today, we have Dr. ALISON Goldenberg. She is one of our breast surgery fellows out of the School of Emory and has been working with our breast cancer team for a couple months now, has recently transitioned back to Emory, but is due back in the end of the year in December to work with our team again. Dr. Goldenberg, I don't want to take too much of the introduction away from you, so I'll go ahead and pass it on to her for her to introduce herself, and we can go from there. So, Dr. Goldenberg.
Sure. Thank you. Thank you so much, Ben. And thank you, Brenda. This is I hope everyone can see my screen okay. I'm really, really happy to be here for this talk. It's kind of the first kind of public outreach I've done since starting fellowship, so that's a really great way. What better time than October, Breast Cancer Awareness Month? So welcome to the Lunch and Learn. Thank you again to Ben and Brenda. Without them, this wouldn't be possible. The Senior Center is, blessed with Brenda. I know she does a ton of work there, and I'm just kind of happy to be a part of it. So thank you everyone for being here. This is me. This is my residency graduation photo. It's a very big needle, but we don't usually use that in breast surgery, but sometimes in general surgery. I just wanted to tell you briefly just where I'm from. I was actually born in the Bronx in New York. My father was a plastic surgery resident there, which is kind of maybe where I get it from. And shortly after he finished his residency, we moved to Danbury, Connecticut. And Connecticut is where I grew up. It's a beautiful place to live, beautiful right now. They have the fall foliage, which is really, really a fun kind of tourist attraction for people to see. I met my husband in high school, and we've kind of been together ever since. We moved to Boston together, where we both went to college. I went to Tufts University, just outside the city, and had a great experience there, and actually stayed on after college to do clinical research at Mass General Hospital in Boston. And then kind of solidified my dreams of going to medical school, which I did. I went to St. George's University, which is actually a Caribbean school. And I did my first year as an exchange student in Newcastle, England, which is a really cool experience. And then I did my second year in Grenada, actually in the Caribbean. And Grenada, if you don't know, it's one of the most beautiful islands in the Caribbean. It's known as the Spice Island, and they're a big producer of nutmeg. And one of the favorite drinks was the Grenada rum and Coke with just a splash of their nutmeg on top. It was really a beautiful drink. And I always think about the beautiful Grenada Island, which I miss so much. And then I made my way back to the Bronx, actually, where I did my third and fourth year of medical school. I did my general surgery residency in Syracuse, New York, which is way, way upstate, all the way up by Canada. Luckily, I was accepted into the Emory Grady program because I really need to thaw out for my 5 years up in Syracuse. It's a very snowy place, about 6 months of the year. This is a picture of Newcastle in England, where I did my first year of medical school. You can see this this is the Millennium Bridge, and it's got this kind of footbridge that goes across the river, and there's a whole series of bridges along the Tyne River, and the boats get through this bridge. It kind of pivots on its axis, so the boats are kind of able to go through under both aspects of the bridge. And this is my medical school, St. George's University. A really beautiful place. I actually lived in one of the buildings in the center there, but imagine spending a year there going to school. It was truly an unforgettable experience, and I really loved it very much. But now on to the rest of the talk. So Breast Cancer Awareness Month, it's extremely important. We want to spread awareness, how people can evaluate themselves for breast cancer, how they can screen themselves, what are some risk factors, and we're going to talk about that today. So specifically, we'll go over the symptoms of breast cancer, what are some common risk factors, which are going to be really important in some patients, and we'll see why, what you can do to reduce your risk of breast cancer, what are some typical screening options that we use that you may experience or have experienced in the past, and then we'll just briefly talk about some treatment options. That won't be the focus of the talk, but just to kind of complete the discussion in case anyone has questions about that. And of course, if anyone does have questions, just stop me at any time. I'm happy to answer any questions at any time. So other than skin cancer, breast cancer is the most common cancer in the world. It is the second most common cause of death related to cancer in women in the United States. Lung cancer is actually the most common in men and women, but breast cancer is a close second. In the United States last year, there were over 270,000 new cases of breast cancer. Most of those cancers were actually in women over the age of 45, over 200,000 cases. And then on the other end of the spectrum, there are less cases, but still a pretty significant amount. Men can get breast cancer too, and there are over 2,000 cases of male breast cancer. We'll talk about why that's important a little bit later as well. And if you look at all these patients who had breast cancer, a very small percentage actually die from breast cancer. Only 41,000 deaths in all of last year. 1 in 8 women develop breast cancer, but only a small percentage, 1 in 38, will actually die of breast cancer. And that's because a lot of cancer that we find is very early and very treatable. We've gotten really good at treating breast cancer over the last 20, 30 years, and we have a really good algorithm for screening and treating. So if you catch this early, then your chances of living are close to 100%. So screening mammograms are going to be kind of the key factor that we're going to talk about, and it has been shown over many studies over long periods of time to decrease the odds of dying from breast cancer, which is the thing that we all want to prevent. That's the most important thing. Now, a little bit about breast anatomy. This is just a kind of a diagram of the most important aspects of breast anatomy that we as surgeons look at that are really important to actually where cancer starts and where it can go. So breast cancer is a type of cancer that starts in the breast. The actual breast tissue is probably further out than you think. It, of course, encompasses the breast itself, but then it extends all the way to the breastbone, to the sternum, and then up into the underarm, into the armpit. So it's actually a kind of a teardrop shaped organ. And so when we're thinking of breast cancer, we also have to be aware of all these other kind of hidden places that may be hiding a breast cancer. Within the breast itself, there are about 15 to 20 sections called lobes. That's on that right-hand picture. Lobes are made up of little lobules, and lobules are the glands that produce milk. All of those little lobules, those little grape clusters, are connected via a system of ducts that get bigger and bigger and larger until they get to the nipple. And that's where the milk goes. Milk starts in the lobules and it goes out through the ducts. The little green kidney bean kind of shapes on the left picture, those are the lymph nodes. And those are going to be important as well because they drain all the waste fluid that the breast makes. So if you think about it, that is the first place that if a cancer is going to move somewhere, that is the avenue at which cancer cells can move into the lymph nodes. So that becomes important when we talk about discovering new breast cancers. Has it traveled to the lymph nodes or not, or is it just located in the breast? And then the rest of the breast is made up of fatty tissue and connective tissue. The yellow in that picture is the fat, and that actually does look like that in real life. Now, how does the cancer actually start? In all our cells in the body, all your healthy cells, there is the potential for any one cell to become damaged at any time. And there's many different causes for that. But the damage happens when a gene becomes mutated. And for whatever reason, that cell becomes abnormal and it leads to growth. We know that cancer cells in the breast typically start either in the lobules or the ducts. Those are the most common places to have a breast cancer start, and then spread to normal tissues. This is kind of the progression of how that actually happens. On the left is a healthy cell, a nice pink regular shaped cell, and then for whatever reason, the DNA, which is the small compounds that make up the cell, becomes damaged. It can be because of genetics, it could be because of radiation exposure, it could be a toxic drug that you take, it could be a lot of different things. But when the regulatory processes in the cell are hindered, that break stays in place and it becomes a mutated cell. The mutated cell, a lot of times it's killed off by the body's own immune system. However, if there's no way to stop that cell from mutating, then it just grows unchecked and becomes a cancer. This is just the progression of that. Now, what are the types of breast cancer we talk about? There's kind of 2 different ways to look at that. On the left side is what we had talked about a little bit already about the cell that the cancer starts from. That could be the duct, it could be the lobule, it could be a mix of both. There are different kinds of cells that can mutate to form a breast cancer. we can also think about breast cancer in terms of hormone receptor. So if you look at the individual cell that may be a cancer cell, what are those little purple kind of figures? Those are the proteins that make up the cell membrane. If those cells are related to hormones in any way, then hormones in your body may feed those cancer cells. So we talk about hormone receptor positive cancer and hormone receptor negative cancer. You can see in a normal cell, we all have those proteins in place. We all have those receptors, but that can get out of control in a cancer cell. If you think about, your body, our ovaries produce estrogen, our adrenal glands, our fat cells, we're producing estrogen all over the place as women. And all it takes is a normal amount of estrogen to feed these abnormal cancer cells. So it's important for us to know, first of all, what type of cancer cell is this? And is this a hormone sensitive cell? And those are the main things that we look for when if you do end up needing a biopsy for any reason. This is kind of the first two things that your pathologist and your surgeon will look at to determine what type of cancer you have. And it's important because we have different treatments for all different types of cancer. We have treatments that block estrogen. So just for example, that's something that we can use to treat. Staging is an important thing as well. This kinds of tells us where you are in the progression of the disease, and it also helps us figure out what we can do to treat you. The big numbers on the top, 0, 1, 2, 3, 4, those are the typical stages of breast cancer that we can see. And depending on where you are, we have different treatment options available for you. Now, if you look at stage 0, 1, and 2, and you go all the way down to the bottom, and you look at the 5-year survival rate, it's almost 100% for every one of those stages. So this is important to show you that if we catch these cancers early, when they're stage 0, 1, or 2, then you have almost 100% survival. That's why it's so important that we raise awareness for people to get screened for this kind of thing. When you get into the later stages, you can still be treated, but you may not be cured. So there's not too much more to take from the slide other than that we want you to get screened so we can catch cancer very early. Okay, now what are symptoms of breast cancer? If you go to this website, knowyourlemons.com, it's a very fun, kind of spins it in a fun way, but these are all, actually, there really are all the types of things we see in patients who present with new breast cancers. So if you have any changes to your skin, right, any thickened area of skin, if there's any redness or warmth, any kind of dimpling of the skin, if you think about what a breast cancer can do, it kind of contracts all the tissue around it. And if it's close to the skin, it can contract the skin, forming this dimple kind of thing. So if you have this new dimple, it potentially could be something to get checked out. You could have a hard mass, you could have a bump, there could be some asymmetry. Some people even have nipple discharge as the first presenting sign of a breast cancer. So definitely something to look out for. If there's any kind of new shape to the breast, or if you notice that your breasts are not symmetric, even things that look like eczema on the nipple can be cancer. So definitely these things are good to keep in mind. And it's important to do breast exams on yourself so you can figure out kind of if there are any changes. That's another good reason to do self-breast exams. Now, what are some other things to know about breast cancer symptoms? So again, I said, if you are doing a self-breast exam, what is the reason for that? It's to know your body. So you know if something has changed. And usually women are pretty intuitive about that, and they kind of know when a new lump or bump has been found, and that is a great time to go see your doctor if something actually changes. So symptoms depend on size and location of the tumor. If it's really deep in the breast, then you may not be able to feel it. But if it's near the skin or under the nipple, you may notice that there's actually a change. Something to keep in mind is that pain is actually not a typical symptom of breast cancer. Breast pain is probably the most common complaint that we see in our clinic. And almost 100% of the time, it is not related to breast cancer. The only times when you may have pain in breast cancer is if there's a tumor very close to the skin and you have irritation of the skin. So pain is a little more difficult to figure out the cause of that, A lot of times it's related to hormone changes in the body, but we may never know the cause. And a lot of times it comes and goes with the menstrual cycle, things like that. But it is typically not a symptom of breast cancer. It doesn't mean you shouldn't get checked out, but shouldn't have too many heightened alarm bells because of that. And now any of these symptoms that we talked about, any of these signs, are also potentially related to benign breast disease. So it doesn't always mean cancer if you have these findings. There can be very simple explanations for all of those symptoms, okay? It just means that we want to see you in our office so that we can better evaluate what's going on with you. And that'll be a discussion as well as an exam and potentially some other diagnostic workup tests, which we will go over in a little while. The slide on the right side is looking at, it's just what the pathologist sees under the microscope when we take a biopsy. And this is showing an invasive cancer of the breast, just kind of what it would look like. Now, what are some risk factors that we need to be aware of? So why do we do this? Why do we do a risk determination for patients? We really want to know which patients are at low, medium, and high risk of getting breast cancer in their lifetime. So anytime someone comes into our office, this is one of the first things we ask. We go over a long questionnaire to find out what is someone's risk of developing a breast cancer in their lifetime. People who are at higher risk may need more frequent screening. They may need mammograms more times in a year. They may need different screening tests, which we'll talk about. This is kind of the breakdown of what your risk is of developing breast cancer based on your risk. So the important thing to remember, though, is that these risk factors are just that. It means that is your risk of developing cancer in your lifetime, but it is not your risk of dying from breast cancer. If you remember, breast cancer affects 1 in 8 women. That is a lot of people. But it doesn't necessarily mean that all those people are dying of breast cancer. This is just means that you have to have a more heightened awareness, okay? So major risk factors. Now, everyone's probably heard of the BRCA mutation. This BRCA mutation and BRCA1 or BRCA2 are genetic mutations. Frequently, it means that this is passed down from family members, and it can significantly increase your risk of breast cancer. So if you have relatives, usually it's what we call first-degree relatives. So that means mom, sister, daughter. If you have first-degree relatives who have breast cancer or more than one, then you may be a candidate for genetic testing to look for BRCA mutations. There are other mutations that happen. Some of them, they have different names. There's a whole list of mutations that are possible. Sometimes all you need is just a family history of different types of cancers. There are many different cancer syndromes that people can have that are not BRCA related. So we always ask about family history of breast, ovarian, tubal is fallopian tube. Any peritoneal it just means the lining of the abdominal wall. Also pancreatic, prostate, and colon. Those are also potentially related to family genetic syndromes. We also ask about what is your ancestry. So for example, the Ashkenazi Jewish population has a higher risk of breast cancer. And then we look for other hereditary breast and ovarian cancer syndromes. There's a whole list. So if you potentially qualify for genetic testing, then we would send out your samples to a lab, and then we would get back all of the reporting on that. Sometimes people have mutations that don't really mean anything. Sometimes they have dangerous mutations, but we kind of have to look at that individual person and figure out what their risk is based off of those results. Anytime someone's had a previous biopsy that showed something abnormal, like a high risk lesion, maybe not cancer, but maybe something atypical that potentially could lead to cancer one day, those people are at higher risk of developing a cancer. And then the other kind of aspect that we don't really talk about too much is radiation therapy to the chest at a young age. So this is like any kind of childhood cancers, any kind of lymphoma. There's lots of other types of cancers that kids get and are treated and people do fine, but that radiation therapy can cause secondary cancer later on. And if you think about it, the younger you are when you get the radiation, the more chance you have to develop a breast cancer or other cancer later on. Now, what does modifiable risk factor mean? The risk factors we just looked at all these things about genetics, family history, all of that, we call them non-modifiable risk factors, meaning this is what you're born with, these are the cards you're dealt, and you can't do anything about it. We just have to know that information and move on. Modifiable risk factors are things that have been linked to breast cancer, may not be direct causes of breast cancer, but definitely don't help. So these are things that you can potentially do or change about yourself to decrease your risk of breast cancer in the future. The Western diet, this is that high cholesterol, high fat diet, leads to many different kinds of cancers. Breast cancer is one. Colon cancer is another that is related to this kind of diet. People should definitely decrease alcohol and smoking intake. Smoking is related to almost every cancer that people get. So definitely can decrease your risk of breast cancer with limiting alcohol and smoking. Decreased physical activity and obesity we see are rising in our country and across the world, and we've seen more episodes of colon cancer and also breast cancer because of that. And then sometimes, I don't know if anyone's experienced this, but going through menopause, you can have hot flashes and other symptoms, and sometimes your doctor will prescribe you estrogen treatments. This is fine for short periods of time, but any prolonged use of estrogen or other hormones potentially can lead to breast cancer. If you remember when we talked about the hormone-sensitive breast cancers, estrogen is one of those hormones, and that estrogen, progesterone, they can feed those tumors. So we want to prevent that if we can, and limit the use of any of those, we call them exogenous hormones. Now, this is a topic that is difficult to discuss because we actually don't really know a lot about it. Why? So what are the differences between races and breast cancer? Now, overall, Caucasian women tend to have the highest incidence of breast cancer. We don't know why that is. We also know that there's the highest rate of breast cancer in young women who are Hispanic or African American. So under the age of 40, the most likely group that will be susceptible to breast cancer are those women. Why is that? We don't know. If we knew, then we would potentially be able to change our treatments or change our screening patterns, but all we know is that that disparity exists. Now, if you look at the chart on the right, this is a pretty troubling chart, and it shows deaths per 100,000 women. It's looking from the year 1975 to 2010, and you can see over time the disparity between deaths between Black and Caucasian women have really increased dramatically, and we don't know why. Is it because people don't have access to healthcare? Is it because those African-American, Hispanic women don't have access to mammograms, or they don't know? What is the reason? And we're always doing research to try and figure that out, but this disparity exists. So that's also another reason to really increase awareness of the need for getting mammograms, because especially in women who may have more advanced invasive cancer at an early age, it's really important to get screened and have it detected so they can be treated and cured, because breast cancer is a curable disease. It truly is. Okay, now, how do we really assess your risk? Of course, we can make this list of, BRCA mutation, family history, but how do we actually calculate that? Now, we have ways to do that. We have computer systems. There's more than one that can account for multiple risk factors that patients may have. So these the models will determine who is at high risk, who needs more surveillance, and some other information. The GALE model you may have heard of. This is a breast cancer risk assessment tool. This is used for women who have never had a history of breast cancer and who don't have strong family history of breast cancer. The reason why just historically it was excluded is because if you have a strong family history of breast cancer, you are already at high risk. So we don't need a model to tell us that. So this does not take into account the BRCA1 or BRCA2 mutation, but it does look at multiple things. It looks at age, race, ethnicity, any personal history of breast cancer. It looks at how old you were when you first got your period, how many pregnancies you've had, any hormone use. So we care about age of first period because you think about it, when you get your period, that's when your hormones go crazy, your estrogen starts up. So someone who has had their onset of their menstrual cycle early on means they've been exposed to more estrogen over their lifetime. So these are all not direct causes of breast cancer, but if you add them all up together, they can increase your risk. So anyone can use the Gale model. Anyone can go online. You can go to the National Cancer Institute. You can type in, answer all the questions and type in all your information, and you yourself can find out if you maybe are at risk, if you have a higher risk than average. So I encourage you all to do that, just to kind of at least get a baseline feel for what your risk may be, or at least think about these questions to figure out maybe if you have an increased family history, or what is it that makes you at high risk. Maybe not, but it's a good thing to kind of start thinking about. Now, these kits are fun, right? The 23andMe. What are some other ones? There's like an Ancestry one, Heritage. There's a couple big companies that have these home genetic test kits. Now, they're fun, but there have been plenty of studies to show that there is a lot of variability between the results of these kits. So it's fine to do, but kind of take the answer with a grain of salt. And if you think that you would qualify for genetic testing, then we do our own genetic testing. And we have a pretty well-regulated lab that will calculate the risk, and it's very accurate. So what are the things that may qualify you for genetic testing? These, you need a pretty significant family history of breast cancer or other cancers: ovarian, prostate, colon, uterine, melanoma. Those are kind of the big, and gastric cancer as well. Those are kind of the big other types of cancers that may mean you have a hereditary syndrome. If you have cancer in every generation, right? If your grandma has it, if you have it, if your daughter has it, there's probably something going on. We also look at patients who have developed breast cancer at a young age, so under 50. If you or more than one member of your family has had breast cancer or any of these other cancers at a young age, you may qualify. Male breast cancer is another thing. If there's any male breast cancer in your family, then you may qualify for genetic testing. And that's because if you think about, so men get breast cancer too, for sure. Everyone has breast tissue. Women, men, it's just less pronounced in men. And there's less estrogen, men produce less estrogen. But if there is a genetic syndrome in that man, and he develops breast cancer, then that's an extremely rare thing. If you remember how many people a year develop breast cancer, it's like somewhere between, around 400,000 people a year develop breast cancer. Only 2,000 of those are men. So those are really worrisome cases when someone has male breast cancer. Anytime you have cancer in both breasts, or if you have a recurrent breast cancer, meaning you keep having problems, you keep having breast cancers in different places, new breast cancers, that may be something that indicates you have a genetic mutation. So any of these things, bring to the attention of your doctor, even if it's not your surgeon, even if it's a family practitioner, your OBGYN, ask about these things, because not only will it help you, but it will also help your children. So genetic counseling is an important thing, that it's an important kind of aspect of treating breast cancer and treating patients that is really important, because this has big implications in terms of your family, right? So we have trained genetic counselors who look at medical and psychological issues related to genetic disorders, and they focus on these hereditary cancer syndromes. We have someone in our breast clinic at Grady who's available to talk about this exact thing. We have a whole clinic dedicated to genetic counseling. And it's going to be a discussion with you and your family and this trained professional. And they kind of go through this whole family tree, and they mark down everyone in your family for different generations and second cousins and, everyone. And they mark down who has had history of what cancer and what does it all mean. So, you may say, well, I already have breast cancer. Why do I need to get genetic testing? Well, this may be important information for your children, right? Or if you're considering having children and maybe you have a family history of breast cancer, something that you want to know, because then not necessarily that you won't have children, but you'll be ready and you'll be able to screen and have knowledge, right? That's what we want. We want people to be knowledgeable and be informed so they can make complete decisions about their healthcare. As a result of these genetic counseling sessions, you may talk about different things: increased screening, What kind of surveillance do we need to do? How do we watch you, right? How do we watch and make sure that you don't develop these cancers? And if you do, how do we catch it early? And then what are some treatment options for you? Okay, so let's talk about a little about screening options. Again, if anyone has any questions or issues, just stop me anytime. I can answer anything. Now, what are screening modalities that we use? Okay, so this is the next step. Now, you've been to your doctor and you've seen them. Maybe you have a family history of breast cancer. You want to be screened. Okay, what do we do? Mammogram, I'm sure everyone has heard of. This is the primary modality that we use for women who are at average risk. So any woman coming off the street at the age of 40, we would say, oh, perfect, you're just in time for your screening mammogram. So, and we'll go over what exactly that means, but on the right side, here's just a picture of what we're gonna see. The picture on the left is this is the same breast looking from different views. So we look from side to side, and on the right side, we do a second view where we look from top to bottom. And that gives us a good 3D picture of what's going on. We do the same thing with ultrasound and MRI for different reasons at different times. You may have an ultrasound at some point. Now, why do we do this? Mammogram is very good at picking up abnormalities. Ultrasound is very good at very specific things. So ultrasound is really good at looking at fluid-filled areas. So if you have a cyst, you have an abscess, something like that, an ultrasound is a great tool to use to see exactly where it is and measure whatever that cyst is or measure whatever that lesion is. Mammogram is just not as good as that. So sometimes we call people back after they've had mammogram because we want to just take a look on ultrasound and make sure we can better characterize whatever problem, whatever abnormality is happening. MRI is used in some women. Now, MRI is a very expensive test, and it's a very sensitive test. And it is typically used in women who are at higher risk of breast cancer, and that's because it can pick up small breast cancers. It can pick up things that maybe aren't seen on mammogram or ultrasound. And the other two things that we do for screening, which are really, really important, are clinical breast exams that your doctor will do, either PCP, OBGYN, your breast surgeon, your medical oncologist. Someone will do that at your yearly visit. And then yourself, you should be doing a breast self-exams. And that is something that can be easily done monthly. The reason for this, again, I mentioned it before, but we want you to be really familiar with your body so that you can be aware of changes that occur. It's kind of for a lot of women, it's the first sign that something is going on when they come in and they say, I felt a lump here. And that finds a cancer after that. Sometimes it doesn't. Many times it just finds benign lesions, but you could find your own cancer that way. Let's talk a little bit more about the details of different kinds of screening tests. Now, I've heard people come into the clinic all the time and, they haven't had a mammogram before, they're a little bit older, and they say, well, I've heard that it hurts, or I've heard that it's really uncomfortable and I'm scared and I don't want to do it. But to be honest with you, and I've seen many of these done, they are extremely easy to do. It's an extremely short period of time that you are actually you're actually sitting next to the mammogram machine. Your breast is in the machine for a very short period of time for 2 different views, and then you're done. People have no lasting effects. People do just fine, and it's really nothing to be scared of. It's a very low dose X-ray, and so we're going to be able to see a 3D view of the breast and any abnormalities that we find. The mammogram is really good at finding masses, so it's really good at finding tumors. It's really good at finding calcifications. Now, what are the calcifications? Sometimes breast cancer presents as a mass, but sometimes it presents as calcifications. And you can't feel something like that. It's only something that we can see on mammogram. And many times that points us in the direction of a cancer that is later discovered. So you may say, oh, well, I don't feel any masses in my breast, so I must be okay. I probably don't need to get screened. But that's not true, because many breast cancers are not in mass form. So that's how we find mammogram is a typical way that we find most breast cancers, actually, because of that. Now remember that this is a very easy test, and radiation exposure is very low. You can even do this during pregnancy. It's really not a big deal. Once a year is fine, no problem. The risk of getting any secondary cancers from mammograms is extremely low. I think being on a plane is like the equivalent of getting like 50 mammograms, something like that. So overall, in the grand scheme of things, very low dose of radiation. And then I talked about the compression, that it's really not so bad. And it actually, because the breast is compressed, it even decreases the risk of radiation even lower. Now, why do we do ultrasound? If mammogram is so good, why do we need a secondary test? So, as I mentioned before, any kind of fluid-filled structure is much easier to differentiate in ultrasound. So you can have a finding on a mammogram that looks like a mass, but then you go and do an ultrasound and find out it's just a simple cyst. So if you've had a mammogram before, or you're planning on having a screening mammogram done, just remember that just because you are called back to have another test, it doesn't mean you have breast cancer. All it means is that we need to look a little bit more carefully just so we can better characterize a lesion. We just want to make sure that what we're seeing is not cancer. And most of the time it's not. About 98% of the time, it's not going to be a breast cancer. It's going to be something benign that doesn't need any intervention. Now remember, the ultrasound is no radiation. It uses sound waves, so also an extremely safe test, painless test, and is done right in the office with no problem. Now, what is an MRI? MRI is a very, very sensitive test, and it is used to determine the extent of breast cancer. So sometimes it's very easy to find that breast cancer on the mammogram. It's a lump, you see the mass, and there it is, and you have no question. But when it's a little more unclear, when you have calcifications, then you may want to see how far do those calcifications stretch. And MRI is really good for that. So it's really sensitive. It's used for high-risk patients, right, who have maybe higher risk of developing small breast cancers that we want to pick up early, because sometimes they can be more aggressive. So this is what a mammogram typically will look like. You'll sit kind of lie face down, and the breast kind of hangs down, and that's how we view the imaging. It doesn't take very long. It's actually not too uncomfortable. Some patients just fall asleep during the test. There's no pain involved at all. And the good thing about MRI is that there's no radiation. MRI uses a magnetic field to get the images, so there's no radiation exposure. It's really good in that way. Now, clinical breast exam, this is something that you would have done in the office. This is usually once a year is what typically is recommended. And what your clinician will do, they'll have you sit up first, kind of flex your muscles. We want to see and make sure that there's symmetry of the breast. Any kind of asymmetry or kind of funny area may indicate that there's something going on, maybe a breast cancer, maybe something benign, but some abnormality. Then we will feel the lymph nodes under the arm and at the base of the neck. And that is because, if you remember, we talked about where the breast drains. So where is cancer most likely to drain from the breast? It's to the lymph nodes under the arm. So we want to make sure that there's no abnormal. Yep.
Don't mean to cut you off, but we do have a question in the chat. Okay.
Oh, okay.
It says, does your menstrual cycle affect the results of a mammogram?
Was the question, does a menstrual cycle affect the results?
Does your menstrual cycle affect the results of a mammogram?
It does.
And it says, in other words, should you have one before or after your cycle? Or does it not make a difference?
There's two. Yes, thank you for that question.
You see the question?
You know what? I'm sharing my screen and I don't see where the chat is. But thank you for reading it to me. Let me see if I minimize this for a second. No.
Does your menstrual period affect the results of your mammogram?
Yep. So it's a great question. There's actually two answers. The answer is yes, it does affect your mammogram for two reasons. First of all, if you have a mammogram during your menstrual cycle, it's going to be more painful, because during your menstrual cycle, your hormones are elevated, and so you're going to have more tenderness in the breast, more swelling in the breast, and that's just what happens. So it's best to avoid mammograms during your menstrual cycle for that reason. Also, the reason to avoid mammograms during your cycle is because all that fluid, all that swelling that you have in the breast will obscure the mammogram results. Not to the point where we can't read it, but to the point where it may hide something that may be very small or difficult to see. So we recommend scheduling your mammogram for in between your menstrual, so like 2 weeks after your period, basically, so that all of the swelling and all that tenderness, everything has gone down, and it just helps us see the a better study, basically.
Thank you.
Thanks. Were there any other questions in that chat?
No, that's the only one.
Okay.
Right.
All right.
Okay.
Great, but just stop, because for whatever reason, I can't see the chat. So if there are, just stop me again. Okay.
Someone said they want you to scroll back to the screen before genetics.
Before genetics, let's see. Is it this one?
Scroll back to the screen before testing. Is that the screen?
They can unmute.
Yes, thank you so much.
Oh, okay, yeah.
Right
Yep,
there.
you can just, you don't have to type in, you can actually just type in like GAIL model into Google, or go to the National Cancer Institute page and just kind of go there. And it should direct you to, it's just called the GAIL, G-A-I-L model.
Okay, can you enlarge the screen a little bit?
Thank you.
It's actually, the screen is maximized on
Oh,
my
it
end.
is. Okay.
I can send you like an email with the link, or I can send an email after to be sent out, maybe.
Okay.
If that will
No
help.
problem.
Okay.
Yeah.
So
Okay.
Allison,
Yeah.
this is Bridget. I'm not sure which questions you've addressed already because I'm kind of between two meetings.
Oh.
Did you speak on breast density? Somebody wanted to know about that?
I did not yet, but you're right. Breast density, was there a specific question about it, or just more about breast density and mammogram?
They wanted you to just speak on it, and also why is it important for seniors to continue to get mammograms past 60 years
Yes.
of age? If you can address those
absolutely.
whenever you get there.
So
Okay.
typically, we think of denser breasts in younger patients, but having seen hundreds and hundreds of mammograms, breast density can persist. So even past the age of 60. And so and not that that is something that, makes us wonder if mammograms are good, because mammograms are still good in patients with dense breasts. But you're right that sometimes we need to do an ultrasound instead. So something that we do now on every mammogram report, it's required by law to write if the patient has dense breasts or not, because it can obscure a cancer or something else. So it's going to be important for those patients to continue to get screened. And the way we determine if something is there or not is if that density changes. So we look throughout yearly, we compare your yearly mammograms, and if something has changed in that density, changed from before, then we call you back and potentially biopsy that area. So you're absolutely right. We look very carefully at mammograms of patients who have dense breasts. Now, the reason we do mammograms past the age of 60 is because if you think about life expectancy nowadays, people live to be 100 years old. So if we can find breast cancer in those women who are older than 60, we know that with a simple surgery sometimes, that's all they need to cure their breast cancer. And if you're expecting someone to live another 30 years or 40 years, then we want to find those breast cancers and treat them so you can kind of be rid of that. So we actually screen people, and I'll talk about it in a minute, but we continue to screen people as long as they feel able to undergo whatever treatment is needed after having a diagnosis of breast cancer. So one thing that would prevent us from screening someone, let's say, is if they are unable to either undergo surgery, or they're too weak or sick for chemotherapy or something like that. And then we would say, okay, there's no reason to do unnecessary tests in patients who can't undergo the treatment for breast cancer. But for a healthy, 65-year, most of our patients are actually over 60. So for a healthy 65-year-old who's kind of fit and, doesn't have too many medical problems, could definitely undergo surgery. Surgery for breast cancer is easy. We're not entering the chest, we're not entering the belly. These are all kind of more skin surgeries than anything else. And people who can undergo that are most people. And then we can cure those patients, even at that kind of older age. But even then, we don't think of 65 as old in breast cancer, right? We still are doing surgery on patients well into their 80s.
Thank you.
Yeah. Anything else we could think of? Or I don't know if there's anything else in the chat, just keep going.
Okay, I'll let you know if I see any more questions.
Okay,
Thank
sure.
you.
Yeah, sure. So just a little, let me just see how many, yeah, I want to make sure we don't run out of time. Okay. So talking about screening, right? The average risk, when we talk about patients with average risk, that's most people. Most women are going to be average risk of breast cancer who don't have family history, don't have genetic syndromes, nothing like that. So we typically start screening patients at the age of 40, and it's the recommendation to get yearly screening mammograms starting at the age of 40. Why don't we screen women under 40? So under 40, and if we're talking about dense breasts, women under 40 have a couple things going on. First of all, you're right about the dense breasts, that mammograms aren't great for really young patients because of that reason, but also they're just much less likely to have any abnormalities or cancer. So the harms benefits ratio, including cost, is probably not worth it to do mammograms in patients that young. Especially if you find something, it's more likely to be benign, and that can cause a lot of anxiety and a lot of unnecessary procedures. So for patients under 40, we typically don't screen unless there's a problem, unless someone feels something or has a family history. Now we get to the moderate or higher risk patients. So moderate risk and high risk, these are patients where we start to think about what can we do to supplement screening. Do we need to do MRIs in those patients to pick up smaller breast cancers, to pick up other kinds of early findings that may be related to breast cancer? And the answer is probably yes. If you have been diagnosed with BRCA1 or BRCA2 mutation, you've had chest radiation, you have another familial genetic syndrome, then you will probably be able to start or should start screening earlier than 40. There's no definitive age that we say you have to start screening by, but probably in your 30s is a safe time to start screening, or in an age earlier than someone in your family had a cancer diagnosis. So if your mother had a cancer diagnosis at the age of 38, then you should probably start screening with mammograms before that. The other thing that we talk about, it's a lot of screening tests, right? It's every 6 months, someone has to get a mammogram or an MRI, alternating, and that's, for life. Do those patients, would they rather undergo prophylactic surgery, do a bilateral mastectomy to kind of just rid their anxiety, prevent all these anxiety-provoking screening tests, every 6 months? Because some patients, it's a lot. Some patients say, no, I can't handle. We just had patients this week come in on a Monday morning after thinking about their mammogram that they were going to have on Monday. They couldn't eat, they couldn't sleep because they were just thinking about, what could this mean? What could I have? The mammogram was normal, but the anxiety is still there. So are these patients candidates for bilateral prophylactic mastectomy? And the answer may be yes. And that kind of depends, that will depend on what you talk about with your genetic counselor and your family, and of course, what you would prefer. So all things to think about. A couple things to just keep in mind. If you have breast implants, you still need screening. Usually when we put in breast implants, we don't take any tissue away, and you still have all that breast tissue there that needs to be examined. So implants are safe to do a mammogram. You just have to let them know, and they can kind of change the angles a little bit just so we can get a better view. If you've had prior breast surgery, you still need screening, right? Unless if you've had all of your breast tissue removed, unless you've had mastectomy done, then you still need surgery. Any lumpectomy, any biopsies, breast reduction, abscess drainage, those patients still needs to be screened. And if you've had something done in the right breast, don't forget about the left side. You still need screening on the left side. And then we talked about this a little bit about why we screen past the age of 60 and when we stop screening. And we only stop screening for mammograms when the life expectancy is either low, so just a couple more years, and then, breast cancer is not going to kill you in that time. So we would rather save people the screening test. We'd rather save people all those unnecessary treatments. And then, of course, if patients have illnesses that, prevent them from undergoing surgery. So benefits and harms of screening. Of course, screening can find things that are benign. It can cause a lot of biopsies. It can cause a lot of anxiety. The false positive rate in mammograms is high, almost 10%. And what that means is you have someone tells you that you actually have an abnormal finding on your mammogram, but then it's biopsied and it's negative or it's benign. That is anxiety provoking. And those are procedures that people are put through that may have no result. Sometimes it's okay because you know for sure that you have nothing dangerous going on, but it's still a procedure and it's still a lot of anxiety. But the benefits have been really shown over the years. Your odds of dying from breast cancer will decrease by 20% if you do your regular screening mammograms. For every 100,000 patients screened, 16 will develop a breast cancer, but overall 1,000 deaths will be prevented, and that's yearly, which is a lot. If you're one of those 1,000 or your family member is one of those 1,000, it's a lot, it's worth it. This is just a summary of that, of kind of everything we talked about, but just for the sake of time, I'll just move on really quickly. I'll talk about just a couple things about treatment. Just to be aware, if you have a mammogram or you have some finding on imaging that needs a biopsy, also, I just want you all to be aware that it is not something to be scared of. A biopsy is, of course, anxiety provoking, but it really is very easy to do. There's different kinds of biopsies. But all this really is a small office procedure. We have you kind of lie down on the exam table, and then we use a lot of numbing medication, we numb the skin, we numb the area that the needle will go, and then we either use ultrasound or mammogram, and it's a very small needle that takes just a sample of that tissue, and then that's it. It's maybe a 10-15 minute procedure, and then you put a Band-Aid on and you go home. Patients, of course, are anxious about this, but people do really, really well, and people have really a decent experience. And then we know for sure, right? So don't be scared of a biopsy. Don't be scared of the mammogram. It's just more information that we're going to use to guide your treatment. That's all it is. Now, if you do need to see a breast surgeon, you do end up having a diagnosis of breast cancer, we have gotten really good at treating breast cancer as a team, as a specialty. And these are all the people on the left side that you will see. We call it a multidisciplinary approach to treatment of breast cancer. And we need the radiologist to really carefully look at all the mammograms you have done. We need the medical oncologist. They're the ones who, if you need, prescribe chemotherapy and other medications to kind of counter the hormones or other medications that you need. If you need radiation as part of your treatment, the radiation oncologist is there, and they sit in on these meetings. And of course, your breast surgeon is there, kind of run the meeting and kind of help formulate the treatment plan and what would be best for you. And of course, plastic surgery, if you wanted that done, if you were going to have a complete mastectomy, we have the plastic surgeon available. We have all these people who are available to help in any way. There's nurse navigator, social worker, extremely important to the process. They are like your point person for any appointment that you have. If you need to have a procedure done, if you need to have, an MRI, any other imaging studies, when your surgery date is, what to expect. These people are truly like your gatekeepers to the breast cancer treatment that you desperately need. So you're in good hands, especially at Grady. We do this at Grady. We have a meeting once a week. We talk about every patient who has breast cancer, and we tailor the treatment to that individual patient. No patient is the same, and no treatment is the same. We do use all of these types of treatments, and we talk about what is best for each patient. And that involves surgery, radiation. How do we get rid of the breast cancer itself in the breast? And then systemic treatment. How do we treat the cancer throughout the body if it's spread? And how do we prevent the breast cancer from coming back? And that is all these different hormonal chemotherapy, immunotherapy, if you've heard of. We use all these 5 modalities to treat patients. Not everyone gets every treatment. Some people only need, surgery, radiation. Some people only need hormone therapy. So it's really dependent on the patient, and we look at every case really, really closely. If we're going to go so far as talk about surgery, there's different types of surgery you can do. Mastectomy is removal of the entire breast, just so you can, not that you would need this, but this is kind of the standard for someone who has breast cancer, is to remove all the breast tissue. And then we've kind of moved more towards breast conservation therapy now, which is just what we call a lumpectomy. and we remove just the area of affected tissue. And then doing that plus radiation gives you equivalent survival benefit as a mastectomy. So as the years have gone on, we've gotten better and better at doing surgery, and we actually do less and less surgery. Surgeons don't work as much as they used to, and now we do a lot less. But you know what? It's better for the patients overall. Now, these are all the websites and all the sources I use. If anyone needs more information about anything I said, you can always just get in touch with me. I can send out any links that you need, and that is it. Any other questions?
I do have a question.
Sure.
I had a brother who had different kinds of cancer in his body before he died.
Boy.
He started out with a simple, well, it wasn't simple. It was lymphoma.
Okay.
Which was, it was myeloma.
Oh, wow.
Yeah, he started out with that, and then
Okay.
they thought they had that under control, but they
Yeah.
didn't, and it went to kidneys, and then it went to liver, and he just, before he died, he had cancer of different parts of the body.
Oh my gosh.
So would I need to have that you were talking about
Genetic testing?
Yeah, testing. So
Well,
if I had to have that, would I have to go to a specialist to do it, or do I just go to my regular primary care and ask them?
Yeah, I would go to the primary care doctor first, because the type of cancer that he had, if it was multiple myeloma, that is not necessarily a typical cancer we think of when we think of genetic syndromes. So you may ask them, obviously I'm not a specialist in multiple myeloma, but it is not one of the cancers that typically goes along with breast cancer, ovarian, prostate, colon. It's typically its own phenomenon. But but you're right, I would talk to your primary care doctor about that, because there may be something I don't know about multiple myeloma, and you may qualify.
Okay, thank you.
Yeah, you're welcome.
Michelle, question.
Yeah.
I'm sorry, Brenda, were you done?
I think some people have put some questions up on chat.
Oh.
Can you see it, Michelle?
Okay.
Allison?
Yeah, now that I stopped sharing my screen, I can see it. Okay.
Okay.
The first was, what is the distinction between a 3D exam and a mammogram, and when would you request a 3D mammogram? It actually all depends on the facility where you're at. So at Emory and Grady, we have standard 3D mammograms that we use for everybody. So everyone who gets a screening test has a 3D mammogram. But you don't really need that for screening. All you need is a view from the side and a view from the top. So you can get just those two pictures and be an appropriate screening test, actually. And that's fine. We're trying to get more people to use 3D mammogram, just because it's a little nicer to see, and it is easier to find abnormalities that way, though. But you're right, there is a difference. So hopefully more places will pick up using the 3D, and we call it tomosynthesis. It's kind of like a video footage goes through the breast side to side and up and down, and that also can give us a really good 3D view of whatever abnormality. But you're right, there is a difference.
Okay. And I think you'll be glad to know that we went from 6 to 30.
Yes, I know.
Very good turnout.
Very good turnout.
So Allison.
Yeah.
The 3D as opposed to the regular mammogram, do you know which the various insurances will pay for more?
I think as far as I know, insurance company will pay for any screening, as long as it's a screening mammogram. It just has to do with the number of views. It has to do with the number of pictures that they take. But screening, it should be paid for. A screening, if it's classified as a screening mammogram, no matter if it's 2D, 3D, it should be covered.
Okay.
Should be. And I don't know specifically for each company though. But we rarely have any problems with patients getting their mammograms covered.
Allison, I think I just heard you say that if I'm doing my mammogram at Emory, it's a 3D?
Yep, Grady, yes, Grady and Emory both have, they have we call it tomosynthesis. It's like It's a
Okay.
pretty cool, actually. It's like a video that moves through. If you think about what scans do, they kind of cut the tissues in slices. And the tomosynthesis, it takes a video of that and gives you, it moves, you kind of like move through the tissues back and forth, up and down. And it gives you a really good 3D view of the tissues. And both places have that, Grady and Emory.
Okay.
Yeah.
One question.
Yeah.
The Emory at Hillendale Breast Center, do they do the 3D?
I don't know the one in Hillendale. Do you, Ben, do you know?
I'm not too
I don't
sure.
know.
I'm not
Yeah, I
familiar
don't
with the Hillendale location.
I know, I only know so the places I know are the Clifton Road, and then Johns Creek does that, and then Grady. I imagine that if it's an Emory's system, they do. I would find it hard to believe that each site would be different, but I just don't know for sure. I'm sorry.
Yes, they do.
Oh, okay. Oh, awesome. Thank you.
Any other questions? Let me see. Here's one.
Yes, let
What's
me
the
unmute
difference?
myself.
What's the difference with
I-
ultrasound?
Yeah, some years ago, I had a mammogram and they thought they found something. I had to go and do the ultrasound. So with the new equipment now, is that the 3D that's replaced the ultrasound?
It has not.
Years
So
back.
you're right. It has not replaced ultrasound. The
Oh.
3D mammogram is our initial screening test. So what that does.
Okay.
Yep, it's the initial test, and it goes
Oh,
through
okay.
and looks at the breast in different views.
Oh, okay.
If there's something that we see on the mammogram that would be best looked at by ultrasound, we call you back for an ultrasound,
Okay.
because ultrasound still is better for some things.
Okay. Okay.
So don't be
All right.
surprised, don't be worried, don't be surprised if that
Oh
happens.
no, that was
Okay.
about 5 or 6
Oh,
years
that was a
ago.
long
I've
time
never
ago.
had to have another one, so I'm
Okay.
assuming I'm okay. I just
Okay,
want
good.
the difference.
Yep, you
Okay.
got it.
Okay.
Okay, any other questions? You can unmute yourselves and ask questions if you like.
There was someone else that started saying something, I think. Did I get all the chat questions? Yes.
Yeah, all the chat questions are answered.
Okay, great.
Okay, you have some nice accolades on chat.
Oh, I know.
Great presentation.
Thank you.
Thank you.
Thank you so
Well,
much.
it's
Allison.
it's really an honor to, treat, it's been like my dream for the last 10 years to like help treat breast cancer patients, and I'm finally here, and it's just an honor to talk to you all, and I hope that you learned something, and be happy to speak again if there's different people who weren't able to come to the chat, whatever people need. You can email me, give my email address out, that's fine. I'll put my email in the, let's see.
In the chat, yeah,
Yep.
go ahead.
And
Okay.
Brenda, I'll be reaching out to you later in the day. I'll provide some additional information if anybody's interested in connecting with Grady and getting screenings. I can send you all that information to send out to this team as well if needed.
Okay, sounds good. Thank you so much.
I do,
Ben.
Brenda, I do have one quick question, if it's okay.
Okay, go ahead. Mhm.
Allison, I know you talked about the disparity in breast cancer
Yes.
among African American, Latinos, as opposed to white women.
Mhm.
Is there any research being done on that? And if not, why?
There is a ton of research. There's a lot of research. And as of now, the most that people can come up with is related to access issues. So access to healthcare, and then awareness of the importance of mammograms. So for whatever reason, we do a really bad job of community outreach. Like what we're doing right now, we do a bad job of that for some reason. And so that's part of our initiative, is to try and improve that, because that seems to be the only, what we can find in the research are the two main factors that create that disparity. So
Can we do
you're
a
right, it's a
better
problem.
job? Is it possible for us to do a better job as a community in getting the information out other than during breast cancer month? Because cancer occurs 12 months out of the year, 365.
You're absolutely right.
However many days there in a year. I've been on so many Zoom calls today, but do you have any suggestions of getting news out about the importance of mammogram and the like more often than the month of October.
Well, yeah, that's a great point. I don't know if now, because I'm new to Emory, at the hospital I used to work at, we had a traveling mammogram like bus kind of thing that would go around the community and give people, you know, mammograms. And I don't know if it's something that
Grady had one of those.
Okay, and so I don't know, that was a way that I know that some places try to get the word out. Like, this is really important. We're gonna send the mammogram to your door, because a lot of times it's transportation issues. People don't have childcare. They can't get to their doctor's appointments. So if we can bring that to you, then that's what we'll do. We also have at Grady, we have a great social work and nurse navigator department who, you know, if someone doesn't show up to their appointment, they track patients down. They will call and call until we get an answer. We will make sure you come to your appointment or get rescheduled soon. And I don't know, with COVID, it's been really difficult because I don't think we can do that, the mammogram bus anymore. And it's been a real challenge during COVID, like especially hard to get people to come into their appointments. We have a lot of no-shows. But I think the best thing that you all can do is, you know, spread the word, right? Like, just mammograms are not scary. It's just to tell people that, you know, like, you know, say I had a mammogram, it was fine. A lot of people come and they're scared because of what someone has told them. They've never experienced it, but they're just fearful because of, you know, word of mouth. So if we can change that in some way, I think we could reach more people. But it's hard. It's really hard to do, you know? And so we don't know what to do about the disparity. So we'll keep trying. We keep trying to do these kinds of presentations and get the word out and, you know, reach as many people as possible. You know, feel free to get my email address out. Yeah, I see someone just talked about a flyer in the newsletter. Yeah, like these are great ideas. And we can, you know, we could talk more about that for sure. Oh, good. Thanks, Ms. Palmer, for writing that on there. I'm glad you're for your upcoming mammogram. Thanks. So yeah, we will keep trying. I mean, I'm always available to talk to anyone. If people want to have another presentation at some point, I'd be happy to do it for more people who are interested.
Okay. Well,
Alison, Brenda,
we'll get that together.
Brenda, can I just add one thing before we close?
Go ahead.
Alison, so let me just share this information. So I have a mammogram that's scheduled for November at the breast center at Hillendale. So I literally just got on the phone to them to see, okay, is it 3D that you're offering? The response I got was, yes, we do 3D, but it's going to be dependent on what your insurance covers.
Oh, really?
So we have the ability, we do it, but if your insurance is not covering it, you're going to have to cover the excess out of pocket. So I'm going to get on the phone to my insurance company to see what it is they cover. Because I've been doing this for at least 10 years there, and I just assumed that what I was getting was the best of whatever is available. So sometimes, you know, we just have to kind of check, dig into stuff,
struggle,
get the information. But just anybody doing it there, just know that you need to find out if it's 3D or just the standard. Okay.
Thanks for sharing that, because I wasn't even aware of that. It's like something for me to really be aware of too. You know, we don't know what's the cost of things. What does a mammogram cost? I don't know. I should know, but it's kind of like in another part of our brains, and we you know, order these tests, but we don't know how much they cost. So you're absolutely right about that. Thanks for sharing that.
Okay, well, we're getting ready to wrap up, and thank you so much. That was very informative.
Yes, it
and
was.
You're welcome.
we really enjoyed everything, and you have so many people talking about how much they enjoyed it.
Oh, well, thank you.
We want you to come back, so I'll work with Bridget and I'll work with Marcia, and we'll get you back very soon. Okay,
yeah.
We may be on Zoom.
That's fine. Whenever. I'm here whenever. Yeah. Whenever.
Okay.
Happy to be here. Thank you everyone for listening. We truly appreciate it. Appreciate you.
Okay.
Thank you, everybody.
So
appreciate
much.
it.
Okay.
Thank you, everybody. Be safe.